Today we're going to be talking about protocols used for ovarian stimulation in IVF. And I want to point out from the beginning that this cannot be a one-size-fits-all approach. There's no recipe approach that will give good results. Each protocol has to be tailored to the needs of the individual. And I've played a very big role in this. In fact, one of the commonest causes of IVF failure is poor eggs and embryos as a consequence of just using a recipe approach to stimulation. This podcast is going to clear all that up.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Vazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Welcome to the Egg Whisperer Show. I have the legend, the most famous IVF doctor in the whole world, Dr. Geoffrey Sher, on today. And I'm so honored to have you back. Thank you for joining us again.
Oh, it's my great pleasure.
So what I want to talk about is something that you're clearly an expert on, and I would love to hear your approach to care when it comes to IVF and how you individualize ovarian stimulation protocols to optimize egg embryo quality and give your patients the best chance of IVF pregnancy. So let's jump right in. What are your favorite ovarian stimulation protocols?
Before I start that, let me say this. This is probably the most important aspect of the entire IVF process. There is no one size fits all for anyone. You have to individualize protocols. It's not that difficult, but it's based upon, before we get going onto what those protocols are, it's based upon some basic physiological principles. And that is that the ovary comprises two compartments: follicles, which are the dark areas that are seen on ultrasound, and the perimeter looks like a honeycomb with a white periphery around it is connective tissue or stroma or theca. Now, it's important to know that the stroma produces a hormone called androstenedione and one called testosterone, the latter being the most important, because this male hormone, testosterone, is the building block from which the follicle will form estrogen. So the testosterone is carried from the stroma or theca in a bucket brigade fashion to the cells that line the inside of the follicle, known as granulosa cells. And there, under the effect of FSH, through enzymatic activity we refer to desmolase and aromatase activity, the testosterone is reformed into estradiol. As this happens, the cells, the granulosa cells, multiply, the follicle stretches and secretions pour into the inside of the follicle. And of course, that's what we use to measure response. We measure the size of the follicles by ultrasound, and we measure the estradiol in the bloodstream. Now, it's very important, essential, to have some testosterone around, or no follicles will grow and no eggs will develop. But the emphasis has to be on there being some testosterone and not too much. Studies have shown that if there's too much testosterone that reaches the follicular fluid, it has the reversed effect. It promotes what we call premature luteinization of these cells that line the follicle. The follicle stops growing, the egg stops developing ideally, and the follicles arrest. And this is a real big problem. What it also does is it causes the egg to develop abnormally. And in biology, if a biological unit doesn't develop properly, it won't ripen or mature properly. The egg develops in the time prior to the trigger with HCG or LH. And what happens is that the development of the egg has to be in an orderly, there has to be normal ovogenesis to get you to the point of triggering. At this point of the trigger, all eggs contain 46 chromosomes, 2 pairs of 23, one from the mother, one from their fathers. And now when you give the trigger, what it does is it sends these eggs into a reproductive division known as meiosis. And the objective is to divide the chromosomes down the middle, shed half of the chromosomes to the periphery of the egg as a polar body, and allow the egg to come out with exactly exactly 23 chromosomes. Obvious reason, the sperm goes through a similar process. It also ends up with 23 chromosomes. The sperm and the egg combine to form the normal human genome in the embryo, known where there's again 46 chromosomes. And as we all know, if the embryo is more or less than that normal genomic 46 chromosome number, then that particular embryo is aneuploid or incompetent. It'll either not continue to divide, or it'll divide but it won't attach, or it'll attach, it'll come loose and miscarry early on, or it'll go on and form a birth defect such as Down syndrome. Now, coming back to the bottom line, you cannot take an egg that is developed abnormally during the initial phase of stimulation and give a trigger and expect the egg to end up being chromosomally normal, because it's the egg rather than the sperm that is primarily responsible for whether the embryo is going to be chromosomally normal or euploid. So you've got to be able to get the egg to the point of the trigger without being adversely affected by overexposure to testosterone. Because if you do that, if you don't do that, the egg is going to get to the point, look great, the follicle, and you're going to end up with eggs that are aneuploid and incompetent. So that's the first aspect of it. Now, what makes the woman's ovary produce testosterone? It can happen from two reasons. One, it can happen because of there being a tumor or a cyst or an endometrioma in the ovary, which activates the stroma, causes too much testosterone production, or it can be hormonal. Very rarely is it because of there being a major overproduction of testosterone. But that does happen with PCOS, where the ovary overproduces testosterone, but it comes from the fact that testosterone ovarian production is the consequence of LH activity, LH being the sister hormone of FSH. And if there's too much LH produced by the pituitary, or given in the form of medication, or if the woman receives too much testosterone as an adjunct to stimulation, then the follicle will suffer the consequences, and you'll end up with luteinized follicles and a higher concentration of poor quality eggs. So the bottom line of ovarian stimulation has to be to individualize and identify those patients who are at risk or previously have received overexposure to ovarian testosterone, and lower the testosterone level. You need some, but you don't want too much. And to do that, and the way you do that, the way I do that, and there are different ways of doing it. You don't have to always follow what I'm saying. But what I do is I put most of my patients onto a birth control pill to start their cycles. What that does is it suppresses both FSH and LH within a couple of days. So they're on the they're on the birth control pill, usually a balanced pill like Desigen or Marvelon in Canada and the UK, or something like that, Orthonovum 135, they're a bundle of them, and a balanced monophasic pill for at least 10 days. And then it can be any length of time. And you'll often hear people tell you, but I've been told by my doctor that the pill suppresses you. It will not suppress you if you use it correctly. And why it suppresses some women is the doctor puts the woman on the birth control pill all the way up to the start of the stimulation. And when that happens, you have suppressed the FSH and LH. And remember that FSH in the few days before the cycle begins is essential to recruit follicles and to have antral follicles, which are those that will respond to stimulation. If you don't do that, then you'll end up with no antral follicles. You'll have preantral follicles that look the same, but they don't have the receptors that allow them to respond to FSH, so they don't develop, and they take longer to develop. They need 5 to 7 days of exposure to FSH to be able to respond and to develop into normal follicles. So the idea is to overlap the birth control pill with an agonist, such as Lupron, Superfact, Buserelin, Decapeptyl, so forth. Then you overlap them with this for 3 days, stop the pill. This expunges FSH out of the pituitary, which will then take the preantral follicles to the antral phase, and they'll now be there ready to respond. And if you overlap them like that with the Lupron, they will not have suppression. If you don't, it's going to take about 5 to 7 days longer for the follicles to respond to stimulation, because they need exposure to FSH, which then only comes with the shots you give the woman. So basically, I put them on the birth control pill for 3 days, overlap with a Lupron, stop the pill. 5 or 6 days later, they have a period. This has another major advantage to me. By lengthening or shortening the duration of time the woman is on the pill, I can make her have a period on the exact day I choose. And since I only do 4 batches of IVF a year in Manhattan, in New York, all my patients start their cycle on exactly the same day. I affect this by shortening or lengthening the front end of use of the birth control pill. And then 5 or 6 days after that, when they have their period, now they get an ultrasound and an estradiol to establish baseline hormonal levels and exclude cysts in the ovaries. And the stimulation begins with predominantly FSH products, such as Follistim, Gonalef, or Fitnorm, or Galutron. Those Follistim, Gonalef, or Puragon. And then what happens is they go on that on a high dosage for 2 days with only a little bit of menopur. I never go above 75 units of menopur in my IVF patients, because menopur contains equal amounts of FSH and LH, and many of my patients have already got an overproduction of LH, so I like to keep it low. And then I start them on a high dose of FSH with a small dose of menopur, and then on the 3rd day, I drop the dose of the FSH in half, double the dose of the menopur to 75, continue the stimulation until the follicles are adequately developed, then trigger them with HCG. You don't give Lupron if the woman's been on Lupron all the way through. And such women that I've described are on Lupron all the way through. So I give them HCG or Ovidrel. But the dose of Ovidrel is 500 micrograms, not 250. And the dose of HCG is 10,000 units, not 5,000. If you give too little, you won't get conversion and proper meiosis in the eggs, in my experience.
What you're saying is you're giving them 2 Ovidrels then, so they're getting 500.
Correct. One shot with 2 Ovidrels, or 1 shot with 10,000 units of HCG, Profasi, Novarel, or Pregnal. Now, that is the standard for the woman who's got normal ovarian reserve and is young. But if I've got women that are older with diminished ovarian reserve, where the AMH level is under, say, 1.5, I will no longer use this approach. 1.5 in American units of nanograms per milliliter, and over 10 picomoles per liter for the patients that come from other European and Canadian countries. If the woman has got diminished ovarian reserve, then I will take a different approach. When the woman gets to, and this is different to the mainstream, because I've used the mainstream approach and find this method to be preferable. The woman continues on the Lupron 10 units until the period occurs. But the moment her period starts, from the very first day, I switch them over to a GnRH antagonist, such as Orgalutron, Cetrotide, or Ganrelix. And they get that. The reason I switch them is because Lupron in these patients can sometimes competitively inhibit the action of FSH. It goes for the same receptor sites. So I switch them to the antagonist, and I give them 250 micrograms of the antagonist daily from the first day of stimulation all the way through, stopping the Lupron at that point. And then we go through the same thing. When they get to proper stimulation, trigger them. In this way, we get a better response. In some women who are exceptionally resistant, who have very, very low ovarian reserve, I use estrogen priming. And in these women, what happens is they either get skin patches or they get injections twice weekly of dalestrogen, which is estradiol valerate, twice weekly, starting at the point that the period begins. We delay the stimulation for a week, and then we continue the stimulation, having primed the ovaries to hopefully, I say hopefully, respond to this approach. That's the general approach that I take. And I never, ever give my IVF patients clomiphene, because again, clomiphene is an anti-estrogen. It's an aromatase inhibitor. It has the effect of lowering egg quality, increasing LH. You know that clomiphene and letrozole both increase the release of GnRH agonist by the hypothalamus, increasing pituitary LH and FSH. So too much LH, again, especially when you give clomiphene to older women or women with diminished ovarian reserve, is not a good idea. So I don't use it, and I don't do mini IVF. I do micro IVF, or what we call EZ IVF, which means low dose of gonadotropins, often not every day, every second day of the follicle, Gonalef and Menopur, but I don't use clomiphene or letrozole in my patients.
And do you have patients take supplements during the cycle at all, like DHEA?
I'm very much personally against DHEA, although I know that there are people that feel differently, and I respect that opinion. And the reason for that is that DHEA is a precursor of testosterone. If you give it the wrong woman, you're going to increase ovarian testosterone, and you've got the poorer quality eggs, I think, develop. But I do give most of my patients human growth hormone, which I start with a Lupron and continue all the way through to the trigger.
So you're giving them HGH even before their stimulation starts?
It starts with a Lupron.
Right. So that's about a week before.
Yeah.
Perfect. Yeah. I think having people, I know that not all our listeners are going to basically know everything that you're saying, because I mean, there's a lot of terminology that maybe they don't understand, but just hearing the words and knowing that, you know, every doctor has their own tools in their toolbox that they use that they feel really comfortable with. And I hope that maybe some of the things that you're suggesting could be things that maybe patients can learn from and bring to their doctor. And that really takes me to the next question. When a patient is going through IVF, how does she know that the protocol that the doctor is choosing for her is the right protocol? So if, let's say, you were a patient and you were going through an IVF cycle, what would you ask to make sure that the protocol is being customized for you?
Well, firstly, there are two factors that help you determine that. The first is the age of the woman, and the second is her ovarian reserve. I reserve the protocol I explained where we use the antagonist on top of the agonist. I call it the agonist-antagonist conversion protocol, or the AACP. I reserve that for women who've got diminished reserve. Women where the AMH is under 1.5. The FSH is helpful, but it's not that helpful. But the AMH is under 1.5. And I use the regular long down regulation protocol where I give Lupron throughout, the one I described in the beginning. I use that for women who've got normal ovarian reserve. And if they are very high responders, we'll very often move on to easy IVF. But there is a problem. If a woman's got a very high AMH, or if she's got polycystic ovarian syndrome, she is at risk of developing ovarian hyperstimulation syndrome. And this is a big, big problem. It's the one dreaded condition that we as people in the field try to avoid, because it puts the patient very much at risk, and also her life at risk if it's wrongly treated. There are ways to treat that. One of the ways you often hear doctors talk about is to use only a Lupron trigger. So to give them the agonist trigger rather than the HCG or the Ovidrol, which is nothing more than recombinant HCG. That is not a good approach. It's good, it protects the woman, it reduces the risk of ovarian hyperstimulation syndrome, but that comes at the risk, at the expense, shall I say, of egg quality. Because when you give a woman Lupron, what you're relying on is her production of an LH surge, or her formation of LH in a surge fashion by the administration of Lupron. And this is a problem because you can't regulate how much LH is produced. And if not enough is produced, especially in women who've got large numbers of follicles, the high responders, the women who've got irregular ovulation or don't ovulate, or have got PCOS and you stimulate them, those ones that are at risk, and you use only a Lupron trigger, their risk will be decreased, but the egg quality will suffer the consequences of inadequate reproductive division or meiosis. So I don't use that. I use a process called prolonged coasting, which I developed and which I basically reported on. It works very well, but it takes some doing to know how to use it, because if you use it incorrectly, you'll make matters worse. You've got to start early enough and not wait too long before you trigger. So it's a whole different category to discuss. If we were discussing ovarian hyperstimulation syndrome, I would go into that in more detail and explain exactly how we do that. But it does avoid canceled cycles and canceled dreams, because if you do it correctly, you can get adequate, good quality eggs. You can override the effects, the adverse effects of conditions like PCOS on egg quality by avoiding the need to trigger early to avoid OHSS. Because a lot of doctors who are faced with high responses will trigger early to get the eggs out before the follicles grow too much and put the woman at more risk. That's wrong. You've got to be able to stagger it by doing coasting or drifting, where you stop the medication and give it a chance for the estradiol to peak and come down before you trigger. If you do it correctly, those women will produce good quality eggs, and you will not end up with the poor quality eggs you so commonly see in hyperstimulated patients or women who have got PCOS.
I think the agonist-antagonist cycle, you should probably name it the Sher cycle. Right? You call it the easy. I think that's a name that you have. I think it's E and then Z. I think I've seen it on your website.
Correct.
Yeah, I love that.
And that's for women with very normal ovarian reserve who want to receive much less fertility drugs. It's far better than mini IVF, which is really bad for the very people that it's given to. Mini IVF doesn't work well in women who are already older and producing large amounts of LH. You're making matters worse. You're adding clomiphene, producing more LH, and you often hear doctors say, well, if we give it more gentle stimulation, it's more natural. Problem in saying that is that you can do a lower stimulation without giving drugs that will increase the production of LH and compromise the eggs.
So I imagine, like me, you probably have patients who bank embryos and do more than one cycle. And then sometimes you do a cycle for someone and you say, you know what, I want to make a change. How do you decide what to change in a protocol? And I'll give you an example. So let's say I have a patient and she has 3 beautiful blastocysts that are genetically normal. I've seen other doctors still change the protocol from one cycle to the next. And I'm just wondering, why did you do that? She had really high quality embryos. And so I'm just wondering, what is the decision making that you go through to change the protocol or stay the same in your patients from one to the next?
That's a very good question. I think there comes a point where if you give too much, you're not going to get any benefit anyway. And that's usually women with diminished ovarian reserve, which means they've got fewer antral follicles, which determines how many follicles will develop. If a woman's got a low antral follicle count and you give her a certain dosage and you are stimulating and she's producing eggs and embryos that turn out to be euploid by PGT testing, I don't think there's any justification in just randomly increasing it. But if a woman's got large numbers of antral follicles and she produces fewer eggs, you can increase the number of eggs, therefore potentially the number of embryos and the number of blastocysts that you can get by upping the dose. You're not going to do that in women with low antral follicle counts. So you've got to look at the history of antral follicle count, how they responded in the previous cycle, and what their age and their ovarian reserve is. Now, in a woman that's in the early 30s, you don't need a lot of follicles. If you get 8 or 9 follicles, you're in Fat City. But if you have a woman who's sitting in her early 40s, where you know in a woman of 42, only 1 in 8 eggs is going to be euploid, or at 45, only 1 in 20 is going to be euploid, you don't want to get fewer eggs, you want more. More eggs increases the chances, provided you use an individualized protocol for stimulation and you don't put extra stress on those eggs. So it's very much based upon previous response, age, ovarian reserve, and how many follicles potentially they're capable of producing if you want to increase the dose.
Thank you for sharing all your wisdom with us about ovarian stimulation protocols for IVF. But I want to ask you one question. Do you have any special sperm tricks that you want to teach our listeners to get the best sperm for day of the egg retrieval? What do you tell your patients?
I wish it's the toughest problem of all. Obviously, in men that have got low counts and have got low motility, you've got to investigate them and look at things like the FSH, the LH, the testosterone, and get an ultrasound done to see if there's a varicocele, which, by the way, rarely is associated with low sperm counts. It's usually a stress pattern where the man's got high sperm counts, low motility, and a lot of immature forms. If you see a low count, it's usually not due to a varicocele, because if you operate on that on the man, it's not going to get any better. So the bottom line is, what is the sperm count, the motility, and the morphology, which is hard to assess. The morphology is very difficult to assess. The guy that did this is a personal friend of mine. I went to medical school with him. His name is Tinus Kruger. It's called the Kruger classification. And he's in South Africa. Very good friend. I'm in constant contact with him. So yes, it's a better form of measuring morphology, but morphology doesn't help us that much. As long as the sperm is moving, it's the DNA in the head of the sperm that you're interested in, rather than how much it wiggles and what sort of morphology there is overall. I think it's helpful to some men to put them onto clomiphene if their FSH is low and they've got low or normal testosterone levels. It'll sometimes, 40 to 50% of the time, have a dramatic result. I think it's helpful to put men onto supplements. There are many, many male fertility blends out there. The one I use is the one I think is the best one. You can only get it through the internet. You cannot get it in a drugstore. It's called Proceptin, Proceptin. And people can get it from the website, which I have no interest in, but people can get it from the website by going to proceptin.com. It's the best male fertility blend by far that's out there. Some people will tell you that if there's a very poor quality sperm, go in and take sperm directly out of the testicles by doing testicular sperm extraction. That rarely has any value. If there's any sperm in the ejaculate at all, you sure as hell don't need to do tessie or whatever. You don't need it.
Unless you hate your husband.
Yes, yes.
Go do that. I'm just kidding. Obviously, I'm trying to make light of something that's very, very serious.
Tessie works very well in certain cases,
sure,
where there's obstructive uropathies in the man, where there's the ducts are blocked or damaged and closed, but it doesn't really help that much. It helps also in men that have no sperm.
Mm-hmm.
You get some sperm, not good quality. The results aren't great, but that's the only hope of using the man's sperm.
Yeah, I use a chip, the micro sorting chip, Zymot, on my cases.
We also use it.
Cool.
We think it's a great advantage. Yeah. And of course, the sperm DNA fragmentation assay, also known as the sperm chromatin structure assay, SCSA, is helpful because the DNA fragmentation index may be helpful, but it's not all. I've seen men with very elevated DFIs, DNA fragmentation indices, father children without a problem. So yeah. I don't think it should ever be a reason for not proceeding.
Right. And I feel like with the Zymot chip, I feel like that has now kind of leveled the playing field.
I agree.
Before Zymot, I would do the DFIs, and now I'm like, unless you're not my patient and you're at a center that doesn't have Zymot, go ahead and do a DFI. And then if it's really high, make sure that they add Zymot to your protocol.
Absolutely. Absolutely. We do that all the time.
Well, thank you again for coming on again as a guest. I would love to have you come back on. I want to talk about unexplained infertility, endometriosis. Will you join us again?
Anytime.
So tell us one more time, where can people find you?
You can go to my website, which is very simple. It's sherivf.com. On that website, if you were to become a patient, which many of you won't when you've got a great doctor like Amy, but if you were to become a patient, you would get a free book download. But there's a way to get the download of my immunology book without becoming a patient. Pick up the phone and call my lovely assistant, Patty Converse, 702-281-7437. 702-281-7437, and she will provide you the link that you can go onto the URL and click on it, and the book will appear, and you can download it free of charge. It's really well worthwhile, only because there's not much of that information out there. So you can reach me by calling Patty anytime, or you can go to the website, and I'll be more than happy to see you. And if you come from Amy, you'll go right back to Amy in most cases. But I'd be most...
Thanks. Just kidding. Maybe not, because you'll get pregnant without my help.
Yes.
Well, thank you. I think you're the best. Thank you for providing your wisdom on my show and for also helping my patients become parents. Really appreciate you.
Thank you so much for having me.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Avazadeh
And you have yet another success story.
Just launched by an East Bay fertility doctor.